the peoples of which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation within Alberta, including Nose Hill Métis District 5 and Elbow Métis District 6.
We just also wanted to say that although this meeting is going to be recorded, we're going to have time at the end for questions where we're going to stop the recording and we're going to encourage a brave space. So if you have any questions, please feel free to type it in the chat as they won't appear in the recording.
Our first speaker will be Dr. Yoko Tarumi. Dr. Yoko Tarumi graduated in 1991. She completed her residency in anesthesia and fellowship with a primary interest in palliative care at Sapporo Medical University, where she also completed her PhD. In 1991 to 2001, she came to the University of Alberta to complete clinical and research fellowships in palliative care medicine. She has been a member of the Division of Palliative Care Medicine, Department of Oncology, and the Edmonton Zone Palliative Care Program. She provides clinical services in the community, acute care hospitals, and most recently, the Cross Cancer Institute.
Thank you so much for introduction and also the land acknowledgement. So I will take on the first talk. This is an approach to chronic cancer-related pain in palliative care clinic. So we talk about the cancer pain from the palliative care lens. The objectives of this talk today, by the end of this presentation, you'll be able to recognize the characteristics of chronic cancer-related pain, review the challenging cancer-related pain management in the context of the longer survival, and discuss the recent findings of the use of buprenorphine for cancer-related pain in palliative care clinic. The palliative care definition may vary at the different location, different geographic, but this is a World Health Organization published in 2022 that palliative care is to improve the quality of the life of the people living with life-threatening illness, and also for the family who are facing the challenges, the same challenges to care their loved one. And this support would also reach out to just not the physical, but psychological and social or spiritual aspect of their life. And this is the palliative care we provide at the cancer center as well. As many of us are aware, the cancer survival rate has been improving dramatically, especially since comparing 1940s, around 25% of the people were able to survive over 5 years. But now, the most recent data showing that up to 70% of the people in the United States were able to live for cancer, since diagnosis of cancer, over 5 years. However, the prevalence of the pain related to cancer remains quite significantly high. And this is all across the different stages of the cancer. And for example, I am showing this in a green arrow. Those people who have completed the curative intent of the cancer do still experience the significant prevalence of the pain. If you look at the second the table, the post-curative intent pain, intent people do experience moderate to severe pain at 22% of the prevalence. So one in more than 5 people do experience moderate and severe pain. If the cancer is so advanced that there's no treatment option available, more than 1 in 2 people do experience some level of the pain, and close to 1 in 2 people do experience the moderate to severe pain. And this prevalence of the pain really goes across different stages of cancer. Also, people with cancer diagnosis do experience a high rate of the chronic pain, so the pain lasting over 3 months. This could be reported prevalence of 30% compared to non-cancer population, which the reported prevalence of the chronic pain is about 15%. And also those people living with cancer with pain do experience feeling depressed, feeling anxious, unable to work, needing assistance for their daily living, and multiple needs that are not met for their longer life, despite cancer being controlled. Reflecting this, the terminology of the cancer pain now officially changed to chronic cancer-related pain based on the International Association of the Study of the Pain. This is reflecting the diagnostic code in the International Classification of the Disease. That was 11th revision, most recent one. And so the cancer pain is now officially under the chronic cancer-related pain. And classical cancer pain, such as visceral cancer pain, that cancer causes the organ-related pain, or the bone cancer pain with cancer-related bone metastasis, or the neuropathic pain related to cancer injured the nerve, are all part of the chronic cancer-related pain. But also the cancer treatment itself can leave the patient with a long course of the chronic pain in a variety of the treatment modalities. Just to think about the chronic pain in general, many of us are very familiar that pain and the social determinant of health are closely related, and social determinant of health are central drivers of the disparities in pain care and also the health outcomes. We often think about social determinant of health associated with certain race or non-dominant culture, but this is not itself is the social determinant of health, but interactions between historical and ongoing racism, discrimination, and limited availability and access to culturally safe healthcare predisposed to poorer pain care. And achieving equity in cancer pain care requires coordinated action across healthcare and policy. And so no one patient, no one clinician can change that, but we need an organized approach to help managing this very serious problem. And there are a link between trauma, pain, and cancer, as well as poor quality of life in the recent research. And research links that adverse childhood events, even prior to cancer diagnosis, and history of trauma-related symptom can also contribute to development of the pain. Cancer survivors with trauma history are at increased risk for re-traumatization given the physically invasive nature of the cancer. The PTSD, the post-traumatic stress disorder disease symptom, advanced stage cancer, younger age, and pain were significant predictors of unmet needs for those living with cancer, especially in the first year and after the diagnosis, first year after the diagnosis, but in the years after that. And having more unmet needs predicted poor life satisfaction when controlling for income, education, and age. However, in the cancer pain guidelines and the clinical practice remain very same the past 40 years based on the number of the guidelines supporting the pain medication to be given as patients experiencing severe pain. And the dose escalation can be justified to help patients comfort. And this was believed that this practice was believed to be outweigh the potential harms over the last 40 years. But however, we have been learning the consequence of the long-term opioid therapy throughout the multiple researches. And this is still lacking the standardized definition, but majority of the studies agreeing that long-term opioid therapy and its consequences often reported when the opioid was continuously used for over 90 days. And the higher dose of the use, especially more than 100 milligram of the morphine equivalent daily dose in the first months of the opioid use, is detrimental to use the opioid continuously. So at the beginning of the opioid was used for the relief of the pain medication, opioid can really help the pain. But after a month or two, patients do experience the tolerance, and this leads to dose escalation because the same dose no longer helps. But when we continue doing so, the people would start experiencing hyperalgesia, means that pain is even more severe than just the normal state of the pain without the tolerance. And that could lead to poorer quality of life, despite the intention was the other way. Physiologically, the body would start adaptation change, especially in the brain, the change in the basal ganglia and the reward network, leading into compulsive taking, because patients do not want to experience the withdrawal sensation and needing to continue to take to feel the good sensation. This can lead to depressive mood and cognitive impairment. Also, the hormone change, such as endocrinopathy, gastropathy, well known for constipation related to opioid, and centrally disordered breathing or the respiratory depression and immune dysfunction. So the intention was good, but the consequence of the use of the opioid could lead to more suffering at the end. What is the buprenorphine in buprenorphine is a relatively new opioid, but it's been available since 1970s and 80s. It was discovered in UK with high hope that this medication would not have the risk of the addiction, which is well known for many other full mu opioid agonists, well known with morphine, fentanyl, hydromorphone. And buprenorphine is a partial mu opioid receptor agonist. Partial means it is an agonist, but the signal that is provided through this receptor is much more gentle than full agonism. And also it is a weak opioid receptor like 1 agonist, which means that anti-nociception or the analgesic effect can be provided without addiction risk. And it is antagonist for kappa and delta opioid receptor. This could often associate with the dysphoria, means low mood or bad mood or anxiety or depressive mood. And so the buprenorphine does deter this effect by blocking these receptors. It is much more potent than well-known morphine, about 20 to 40 times when used, and it is a much longer duration of the action of the analgesia. The ceiling effect on the respiratory depression is lower level than when trying to achieve on the painkiller effect analgesia. So when we're using the buprenorphine, patient can acquire the respiratory depression ceiling effect or the tolerance, and can continue using the painkiller effect without risk of the respiratory depression. It is extensively excreted through the bile, so it is going through the feces. So those people who doesn't have a good renal function, or kidney function, can safely use this opioid. It is a substrate of the cytochrome enzyme, namely 3A4 enzyme. And so when we use the drug that is interacting with this enzyme, could lead to overdose or could lead to low efficacy of this medication. This medication is not known to downregulate the expression of mu opioid receptor at the neuron surface. Means that medication will lasting longer instead of losing its efficacy by internalizing the mu opioid receptor in the neuron surface. Here we have a typical scenario that we meet in our clinic. Young 39-year-old person married with two young children, diagnosed with advanced neuroendocrine pancreatic cancer involving the liver and retroperitoneal masses, and undergoing the life-extending cancer therapy. This person has past use of the substances and also currently actively using the nicotine, namely tobacco, and cannabis, namely marijuana, and has been missing appointments due to severe abdominal pain and affecting the treatment plan, and also the helping this person to feel better. He also has a significant weight loss and nausea vomiting, despite using the hydromorphone at higher dose. And by calculating the amount of the dose per day, this person was using at least 360 milligram of morphine equivalent daily dose. After we meet with this person, we agreed to start on the buprenorphine and naloxone combined tablet sublingually. This person stayed on this treatment for the next 24 months without changing dose, but with a good pain management throughout. Until a few days prior to his final day, he passed away in the palliative care unit in Edmonton. The naloxone here is added agent to deter the risk of the overdose risk if that person has decided to use this drug injected intravenously. But when it is taken sublingually, naloxone has very low absorption, less than 10%, and also its efficacy doesn't last more than 60 minutes. So the buprenorphine it remains the main medication when we use this medication. And so the research question that we have raised was to describe the use of the buprenorphine and naloxone combined tablet sublingually in palliative care palliative care clinic for the treatment of the chronic cancer-associated pain in the people with advanced cancer undergoing the cancer therapy. And we hypothesized that the switching from the other opioids to buprenorphine naloxone may result in improved analgesia. So this study was already reported in the Journal of the Pain and Symptom Management last year in October. And so those people who may be interested in are encouraged to read. And the study setting was at the Cross Cancer Institute in Edmonton in Canada. And patients are all seen in the multidisciplinary palliative care outpatient clinic. Referrals are made mainly from the oncologist for treating the people with cancer for life-extending treatment. And when the symptom is under control, uncontrolled, we often receive the referral to help assisting the symptom management. During the time of the study, this was actually happened to be during the pandemic. 1650 consultation was done, and retrospective chart review identified 55 switches attempted to buprenorphine and naloxone tablet. We had included 47 people into analysis. The 8 was removed because of some of them second attempt to switch back to buprenorphine, and few of them did not tolerate after first dose, so we had to stop the medication, and some people decided not to initiate the medication despite agreement. So the 47 remained in this analysis. And male female was almost comparable, and mean duration of the opioid use prior to we have switched to buprenorphine to naloxone tablet was 18.3 months. So you can see that long course of the opioid use, even prior to switching into buprenorphine in this study. In this table, I have already divided into people used the buprenorphine naloxone tablet over 3 months and less than 3 months into two groups, because we find that people who could not take the buprenorphine naloxone longer, this seemed to be less appreciated this efficacy. And so we wanted to see if there's a difference in these two groups, and realized that the major difference was that people who did not stay on the buprenorphine naloxone longer than 3 months did live much shorter than people who did well on the buprenorphine naloxone more than 3 months. So the difference was the 5 months of the median life expectancy to 12 months in those people who stayed on longer on the buprenorphine naloxone tablet. The Edmonton Symptom Assessment Scale is one of the standard tool to assess the patient's symptom presentation, and we use this tool across the cancer care through multiple appointments. And we looked at the assessment that was provided during the course of the follow-up, and we arbitrarily used the T1, T0, T1, T2, T3, T4, approximately post buprenorphine naloxone starting 2 weeks, 4 weeks, 8 weeks, and 12 weeks of each assessment score. And when we looked at the pain scale that was reported by those 47 patients, we realized that there's a trend of the decreasing pain rating over the course, as you can see on this graph. When we looked at the difference between the people who used the buprenorphine naloxone tablet less than 3 months and over 3 months, there's a difference you can see in the green or blue graph is for those people who used longer than 3 months, and the red graph is the one that used less than 3 months. And we also looked at any other factors differentiating the pain rating at the different points. And we look at the male-female difference and happened to found that the male being in a green-blue line and the female being the red line, showing that female patient did seem to struggle with pain much more than a male counterpart. Male patient tends to experience the analgesic effect over time and sustained. So after this analysis, we realized that pain score significantly diminished over time, and buprenorphine naloxone tablet was taken over 3 months, was also significantly lowering their pain rating compared to those people who used buprenorphine and naloxone tablet less than 3 months. So we are in the process of looking into phase 2 trial to test the protocol of this medication, how to provide the service. But we also anticipate that you can tell this is a very challenging situation that patient is at with very aggressive cancer, but yet cancer is in control for many months or years, continue to experience the cancer-related pain, either related to the initial injury to the tissue or added in assault to the body related to treatment and needing the pain management for such an extended time. And we realized our population was much younger. In this study, population was much younger than our general population that we provide service in our outpatient setting. And because I think these people do struggle with symptom, also the lacking support and needing more medication support as a result. And this is a very difficult population to support all throughout the cancer therapy. And so if we were to conduct the study, it will have to be very inclusive of the persons experiencing social determinant of health, but also anticipating the recruitment and communication, also transportation for appointment and supportive care needs are very high, and we need to address these unmet needs. And outcome analysis may be also difficult because you can imagine that this is not just a single effect of the painkiller, but it is some of the support that we provide for this population, and teasing out how much this is the medication effect and also how much is actually comprehensive care, providing the improved perception of the pain and coping, impacting on the outcome of the pain analysis is also another challenge that we anticipate. This is our colleagues in a clinic, including the spiritual care, psychology, physical therapy, occupational therapy, pharmacist, SLP, you also the dietitian, physician, nurses. So we consist with this large number of the staff, try to interact with patient at a different point, multiple occasions throughout the cancer treatment trajectory. So this is my talk. And I would appreciate any feedback or the question after the Dr. Scheff's presentation. Thank you so much.
Thank you so much, Dr. Tarumi, for that wonderful talk. This is just a reminder, if you have any questions, please put them in the chat so we can address them after the seminar. We'll now move on to our next talk, which will be by Dr. Nicole Scheff. Dr. Nicole Scheff is an assistant professor in the Department of Neurobiology at the University of Pittsburgh and a member of UPMC Hillman Cancer Center. Dr. Scheff's translational research program investigates the neurobiology of cancer pain, focusing on how peripheral nerves within the tumor microenvironment drive both pain and tumor progression. Her work has revealed critical mechanisms, including sympathetic sensory nerve interactions and the immunosuppressive effects of opioids on cancer immunotherapy. A recipient of multiple early career awards, including the Rita Allen Foundation Pain Award and Hillman Fellow for Innovative Cancer Research, Dr. Scheff is pioneering neuron-targeted therapies to simultaneously alleviate cancer pain and improve treatment outcomes.
Right. Thank you very much. That was a really interesting talk from Dr. Tarumi, and there's a lot of parallels here, so this will be fun to sort of see. I didn't know she's going to talk about that, so that's cool. See how the things overlap. Okay, so thank you for the introduction. You guys can see my slides. Looks good. Yes, great. Okay. So I'm going to start by so a lot of the stuff, because I know we have a mixed audience, I'm going to reference a lot of commentaries and like general literature to support my themes here, but I'm going to start off talking about this commentary written by Dr. John Liebeskin. And John, this is written in 1991, and he's a renowned pain neurobiologist and a clinical psychologist from UCLA. And he made some really massive discoveries in his career in terms of how the peripheral and central nervous systems interact and modulate communication for pain signaling. And so actually, UCLA wrote a magazine article when he passed, calling him the Prince of Pain. And this is a really cool paper if you're interested at all in learning about him. They do a great job talking about him. If he was interested. But so John wrote this commentary describing this idea that in mouse models, so evidence from laboratory experiments, to show that when the animals with cancer experience pain, the pain actually accelerates the growth of the tumor and makes the cancer worse. To the point where he sort of does this soapbox moment or this call to action saying that if you fail to relieve pain in cancer patients, it's actually going to be worse for them and you're going to exacerbate the disease and lead to death. So it's super important that we acknowledge pain that's being experienced by these patients and don't discredit it for the pursuit of just treating cancer. So a really interesting idea, and this was proposed in the 90s. And unfortunately, in 1996, John sought medical attention for pain when swallowing and was diagnosed with a laryngeal tumor in the fall, and that tumor was resected. And then in the spring of the next year, he then had chest pain and went to the doctor, and they found that the laryngeal tumor had recurred and there was metastasis in his lung and beyond. And then actually John passed away in 97, so about a year after his initial diagnosis. And I think this is so interesting because he had this academic finding in recognizing pain and then was unfortunately forced to experience it himself. And I think it's a really interesting thing to think about as we explore the pain neurobiology that underlies cancer pain. So what is cancer pain? So in John's story, he experiences pain and that's what brings him to the doctor and that's how he gets diagnosed. So I think if you're going to think about cancer pain, we got to take a step back and think about what is cancer, why it occurs, and then how it's interacting with the nervous system. So at least you thinking primarily about blood cancers and solid tumors, it's a normal cell that undergoes genetic changes to get a mutation that results in uncontrollable division. And these mutations also allow for the tumor cell to interact with the environment and tell the host that I am self, don't destroy me. And so there's two mechanisms there, one where it's growing uncontrollably and one where it's telling the nervous system and the immune system, I'm supposed to be doing this, don't attack me. And so those are two things to sort of recognize. And so why is the cancer painful? So your body is innervated by all these different kinds of peripheral nerves. And I'm going to focus on sensory because this is a talk about pain. So you have a sensory nervous system, you have sensory nerves that innervate the body, and their job is to sense the environment and alert the brain of injury, of damage, of dysregulation that's occurring. So just for example, you have sensory neurons in your mouth that signal to the brain for the perception of pain when a liquid is too hot for consumption, or when you get too excited when eating and you bite your cheek or your tongue. And so there's a sharp shooting pain that occurs. That's sensory neurons that are driving that signaling. Even in the throat, you get pain associated with a viral infection and inflammation that's targeting that viral infection. You get a sore throat in response to that. So we have all of this innervation in our body that responds when there's dysregulation or damage. So specifically with cancer, research over the past several decades has demonstrated that cancer cells, as they divide, they release proteins and mediators that, can you guys see? Probably not. I don't want to do it. Anyway, the cells release mediators that can directly activate those sensory neurons. So while the tumor is dividing out of control, you can get crushing and damage and pressure on the nerves, pinching of the nerves, which can cause pain. But you also get this mediator interaction where the tumor is releasing things that can activate the neuron and cause signal to the brain for pain perception. Interestingly, this is not true for every cancer, right? A lot of the most common ones that we can think of, breast cancer, melanoma, kidney cancer, even lung cancer really isn't painful at the primary tumor site. So you don't know you have cancer until you undergo a routine screen, whether it be a mammogram or some other kind of screen in which you pick up a lesion in the kidney or an internal organ. And that is really interesting, right? Because we've done all this work to show that the tumors can release these mediators and that can activate sensory neurons. And the sensory neurons are innervating all over the body, but you don't get that pain percept all the time as the tumor grows. And as a pain scientist, that's a super interesting question to me. And unfortunately, I don't have any good reason for why that is. There's some hypotheses out there about endogenous opioid signaling that's inhibiting the nervous system. But it's an active question of research, and hopefully we'll have something to think about. Well, hopefully we'll have some findings soon, but for now I can't answer that question. But there is research to suggest that there's direct communication. So there are lots of different strategies to treat cancer. So not only can you have direct tumor pain, you also get pain associated with treatment. And that's a lot about what Dr. Tarumi probably sees in palliative care as patients that are undergoing cancer treatment. And now we have pain associated with that. So the standard of care for patients can vary depending upon cancer type. And often this is surgery followed by chemoradiation, depending upon the stage and location. And actually, on Monday, I think, or Tuesday, there was an article that came out in the New York Times, and it's this really well-written article by this journalist that describes the pain associated with the surgery to remove his kidney because he was diagnosed with kidney cancer. And he describes that the kidney cancer itself wasn't painful, but the surgery to cut into his abdominal wall or remove the kidney and the pain associated with that. And it's just really interesting, and he writes very beautifully. So if you're interested, you should read that. But so there's a bunch of different treatment strategies, and I'll take a step back. And thankfully, the oncology field is not just sitting by and letting surgery and chemoradiation be the only strategy. Okay, so the oncology has done a lot to try to find new treatment strategies for cancer, and this is an ever-growing field with new stuff coming out constantly. And as we get better at translating bench work to clinic, a lot more things are coming out. So now in lots of tumors like breast cancer, ovarian, even blood cancers, they're doing genetic testing. So they do a genetic profiling of the biopsy to try to understand what the genetic mutations are that underlie your specific tumor. And that will aid in deciding what kind of treatment strategy you could use. So breast cancer is a great example because they're doing a lot of genetic profiling. So my mom was just diagnosed last year with early stage breast cancer, and they did the biopsy, and it's estrogen receptor positive breast cancer. And so that means she got a lumpectomy. They removed the tumor because it was borderline stage 1, stage 2, and then now she's on hormone therapy that blocks estrogen signaling, because the fact that the tumor had estrogen receptors suggests that it's dependent on estrogen signaling. So now she can take an estrogen receptor inhibitor for a while to try to prevent recurrence from that tumor. And that's all based on genetic testing. This is also true with pancreatic and ovarian, where they can look at enzyme activity. So a PARP inhibitor can be used to reduce this PARP enzyme that's involved in DNA mutations. And that's all based on testing. Unfortunately, I bring up all of this because while all of these treatments are really cool and there's big advancements in oncology, pain is also associated with almost everything that they're doing, unfortunately. So that hormone therapy that's associated with blocking estrogen receptor signaling, you can get musculoskeletal pain associated with that. Surgery, of course, causes nerve damage, and you can get chronic pain in response to that. Bone marrow transplants for blood cancers, you can have adverse immune reactions. The mucosal lining can develop these really severe ulcers and inflammatory reactions. Chemotherapy causes tingling and pain in your extremities and what's called chemotherapy-induced neuropathy. Radiation even causes these ulcerations in the gut and then the oral cavity. And then immunotherapy is the biggest push in oncology. And this is a mechanism to drive and boost your immune response, the host's immune response to the cancer, so that you can kill the cancer naturally yourself. Unfortunately, these immunotherapies also cause immune-related adverse events. And so you can get dysregulated inflammation unintended by the treatment. And this is usually because all of the stuff that we're doing in cancer treatment to look at the tumor and figure out why is the tumor different, how can we target it, there's a lot of redundancy because the tumor is just a transformed malignant cell that's in your body, whether it's a keratinocyte or an epithelial cell. And so there's a lot of redundancy in these mechanisms. So, for example, for pancreatic cancer, if you're targeting that PARP activity is used all over the body to modulate DNA repair. And so you're giving the drug systemically, and so you're causing dysregulation of homeostasis in other areas of the body, which is also how these pain conditions occur. So what's the issue with this? John's commentary and story suggested that you have to recognize pain in the patient because pain leads to stress, leads to exacerbation of the tumor growth. And then patients will also stop their treatment due to pain. And if you stop your treatment in the middle, this can result in reduced therapeutic response. And I think radiation is a great example of this, where radiation in the head and neck region can cause this really severe ulceration and inflammatory reaction in the oral cavity. And patients will stop their radiation halfway through because they're losing weight, they can't eat, they have these really bad ulcers in their mouth. And when they stop halfway through, the tumor will gain what's called radioresistance. So it'll mutate and no longer be sensitive to radiotherapy and now be resistant. And so if radiation's not working, then you have to pivot to other things. And in the head and neck region, they're trying to shrink the tumor because resection is hard in the face. So that's a problem. And you get high rates of recurrence then and metastasis. Treating the pain can also result in additional therapeutics. So now you have to give additional analgesics. And Dr. Tarumi, mentioned the issues with opioids and maybe this transition to buprenorphine, naloxone, which is really interesting. But then the question is always, does that analgesic interfere unintended to any of these oncologic therapeutics that they're trying to do? So do you get cross-reactivity? And that's sort of important to know. And then patients that undergo some of these treatments will end up having long-term chronic pain that severely reduces quality of life. And a great example of this is prophylactic mastectomy in order to prevent breast cancer. So if you have the BRCA mutation, you think you're going to get breast cancer, maybe you'll just go ahead and get that prophylactic mastectomy. That surgery can actually cause deep itch and deep chronic pain in the chest area. And so now you're living with this chronic pain condition that severely decreases your quality of life. So these are all things I think we have to think about when we're envisioning cancer pain and the best way to treat it. Okay, so back to John, because I like his story and his lesson. And so again, his soapbox moment was this idea that we can't ignore pain associated with cancer, and pain can worsen the disease. So I think this idea is taken fairly seriously clinically. From what I could tell, you just heard from Dr. Tarumi in palliative care, even the medical oncologists that you talk to really consider, they want to make sure that the analgesics are on board, that the patient is not undergoing pain. It's not really thought about beyond that, I think. And so I work closely here with the director of head and neck cancer survivorship, and I work closely with radiation oncology. And analgesics during cancer treatment are definitely a priority. The patients are on analgesics. And so I'm going to use head and neck cancer as the primary example because that's what I think about the most. And so this is Brian Schmidt. He is a maxillofacial surgeon at NYU, and he has a basic science lab that focuses on understanding why head and neck cancer is so painful. So these patients at diagnosis complain of pain, just like John, who had pain swallowing, and then he got diagnosed with laryngeal cancer. These patients come in experiencing a lot of pain. And so they are given opioids at diagnosis to treat that pain, and then subsequent standard of care to treat the cancer is initiated. So here at Pitt, this is Dan Zamberg, who's a medical oncologist who treats mostly recurrent metastatic head and neck cancer patients, but head and neck cancer. And he is very interested in checkpoint therapy. And so this immunotherapy. And so he does a lot of clinical trials with immune checkpoint inhibitors. And so what these are is they're targeting to disrupt the communication between tumor cells and cytotoxic T cells. So the tumor cell has this programmed death ligand that it expresses, and the T cell has the counterpart to that. And so when the programmed death ligand binds to its counterpart, it turns the T cell off. So basically tells the T cell, you don't need to do a programmed death thing on me. I'm cool. I'm part of you. And so it turns the T cell off. And the oncologic field has found that you can disrupt this with these immune checkpoint inhibitors, so these antibodies against PD-L1 and PD-1. And when you disrupt that, it allows the T cell to come in and kill the cancer. So in talking with Dan, less than 20% of our head and neck cancer patients actually respond to these checkpoint inhibitors. And it's on paper, it's not totally clear because the cancer cells express a lot of that programmed death ligand, and the T cells are there, but they're not responding. And so we started talking about what else these patients are doing, and they're on a lot of these opioids at diagnosis. And so we sort of asked this question, are these opioids interfering? And there's literature from the 90s showing that opioids themselves are in fact immunosuppressive. So if you're on opioid analgesics to treat your pain, your immune system is wholly expressed. The mechanism for why is sort of unclear, but they do know that immunosuppression happens when you take opioid analgesics. So we asked this question, are the exogenous opioids that we're giving for pain treatment in these patients messing with their response to these immune checkpoint inhibitors? And sort of the underlying idea for this is if you have a drug on board that's suppressing the immune system and then you're trying to give them a drug to ignite their immune system, these two things are counteracting each other and you're going to get a null response. So I'm not going to run through all the data because that's boring. I'm going to give you a quick and dirty version of this. And so in 2023, we did a retrospective analysis with Dan Zandberg and looked at recurrent metastatic head and neck cancer patients and found that, yes, these patients that are on high doses of opioids at the time of immune checkpoint therapy do much worse than the patients that are not on opioids. And so we took this finding and translated it to mouse models to look at it directly and sort of ask the question, why, what mechanistically is actually happening? And so we took mice, we gave them cancer, and we gave them morphine. And we found that the morphine actually restricts the recruitment of immune cells to the cancer. So the mice that were on morphine, while they had less pain, they also had a lot less cytotoxic immune cells in their tumor. And so if you don't have those cytotoxic immune cells in the tumor, then giving the immunotherapy won't work. You need the immune cells there. And it looked like morphine's restricting that. And so this was in 2024. Since then, this has sort of taken off. And a lot of interest has grown now and not outside of head and neck cancer. So now there's some really interesting data coming out of a group looking at non-small cell lung cancer, in which they're seeing that morphine use impacts non-small cell lung cancer patients as well. There's a Nature review that just came out in which Arabella Young really looks at all of the data over the past couple of years in this 2026 article, sort of highlighting all of these different studies now that are popping up, showing that maybe there's this interaction between opioid use and response to immunotherapy. This last 2025 commentary is really nicely well written and really thinks about the patient. So what's the clinical implications of this? What do we do? And again, I'm going to keep bringing it back to John Libeskind, because you can't just ignore the pain, right? So what the data that I've put out is not good. It's this idea that we have opioids to treat cancer pain. That is the primary, most reliable treatment strategy. And yet it's blocking the efficacy of one of the newest, most compelling therapeutic strategies to treat cancer. And so that's a bad thing. And so like we can't take the opioids away. So what do we do moving forward? So yeah, so the primary concern is that the cancer pain treatment strategies that we're using have to consider the standard of care cancer treatments. Otherwise, you're going to get negative results. So back to the literature. So, you know, I published this work with Dan Zamberg, and he's the medical oncologist treating the patients. And, you know, he's still prescribing opioids. Even though we have all this really compelling data, he's still doing it because that's the only thing to do. And you have to treat the pain. So there was, in 2016, Jonathan Moss and his colleagues published this really interesting observational study looking at advanced cancer in the palliative care setting. And they found that patients that are on methyl naltrexone, which is a peripherally restricted mu-opioid receptor antagonist, PAMORA is the acronym. So methyl naltrexone is given for opioid-induced constipation. When you take opioids, you have all these side effects. One of them is constipation, and you can give this methyl naltrexone, which is it's a methylated drug, so it can't cross the blood-brain barrier, and it reduces peripheral side effects of opioid use. And Jonathan found that in patients taking methyl naltrexone, they actually lived a lot longer than the patients that weren't, sort of suggesting that peripheral modulation of the mu-opioid receptor aided in survival. So that fed into what we were looking at in our mouse model, and this idea that morphine was restricting T-cell recruitment into the tumor. So in our mouse study, we actually gave the mice methyl naltrexone and found that if you give morphine plus this peripherally restricted receptor antagonist, you can keep the analgesia on board, but you can block the peripheral immunosuppression that the morphine is driving. So this would be our solution to this idea where you want the analgesia, but you don't want the side effects. And you can use a PAMORA to do that. And so since then, we actually paired up with Lauren Johnson, who is an author on this paper. He started his own company called Glycix, and he created his own more potent version of methyl naltrexone. And we are beginning to recruit for a multi-site phase 2 clinical trial to look to see if we can use his PAMORA, which is called Excelapran, as a lead-in. So give it to patients prior to immunotherapy, the patients that are on opioids or not. I think we're opening up to anybody, and see if that'll improve response in this head and neck cancer population, in which the response rate's really like 12 to 15%. Can we move the needle if they have this peripherally restricted opioid antagonist on board? So that's exciting. It's an interesting study just to show that you took a clinical observation, mechanistically tease it apart at the bench, and then we can translate it back to clinic. So hopefully we get some positive results for these patients with this trial. Okay, so the other side of my lab, which I am not going to go too deep into, but is what if we didn't have to use opioids at all? I know it's the most reliable treatment strategy right now. It would be great if we had another alternative, though. So we're also looking at the idea of targeting that sensory neuron population specifically to treat the pain instead of giving a systemic drug. And so this is a cancer cell commentary that I wrote with Brian Davis that sort of writes in a very generalized way what we mean by this, if you're interested. But this is all based on this observation that Brian had in 2016, again, big year for big observations, in which he found that sensory neurons are actually involved in pancreatic cancer initiation. He did this mouse study in which he got rid of sensory neurons, and in this mouse study, the mice didn't get pancreatic cancer. And so he showed that these sensory neurons are not just bystanders that transmit pain, but maybe they're actually involved in cancer initiation as well. So they wrote a review about stopping nerves to actually treat cancer, not just cancer pain. And this actually triggered a think tank meeting by Eken Demir in Heidelberg, Germany. And so we all got together and talked about how we could do this. Can we clinically target the sensory neuron or the sympathetic neuron as a way to treat or to influence cancer progression? That think tank meeting was in 2019. And since then, the field of cancer neuroscience has grown a ton. We have an international meeting coming up in Houston in a couple weeks, February 18th. And we also have a Keystone meeting in Keystone, Colorado early next year. And you can see the field really growing and pushing to the point where just we can think about sensory neuron cancer interactions, both at the level of influencing the tumor microenvironment, the immune response, but also preventing pain. So we can kill two birds with one stone here. We can impact the pain response, but also help the therapeutic strategies for treating cancer. So I will stop there. If you're interested in anything we do, my lab, please visit my lab website. We have a lot of explanations, some of the other strategies for the sensory neuron targeting that I talked about on there. And then I've just highlighted the people in the lab that have done the most work. Lisa is assistant professor in my lab, and then the clinical collaborators that I can't do any of my work without. And I look forward to having a discussion.
Awesome. Thank you so much, Dr. Scheff and Dr. Tarumi, for those really interesting presentations. We'll now be moving on to the Q&A portion of this seminar, so we'll be stopping the recording. Please feel free to unmute yourself and ask a question or leave it in the chat.
So I guess I can actually start us off. I had a question. Looking at Dr. Tarumi's data, we saw that there was a sex difference in her results, and I was just wondering, Dr. Scheff, in your foundational research, do you also